the RHN Music Therapy online lecture. We're going to be talking a bit about how music therapy adds value in the rehabilitation and treatment of people with a neurodisability. But before we start, I'm just going to say, if you have any questions, can you pop them in the Q&A, and we'll answer all the questions about all of the presentations right at the end. So we're going to hear from 4 different people. I'll give you a little bit of an introduction to the RHN and who we are. So we're the Royal Hospital for Neuro-disability, established in 1854. The RHN is a charitable hospital and research centre located in Putney in London. And we specialise in providing care and rehabilitation for adults living with complex neurological disabilities, including those resulting from acquired brain injuries such as TBI and stroke, and progressive conditions like Huntington's disease. Our services include level 1 and 2A rehabilitation, what we call our brain injury service, neurobehavioural service, ventilation and complex respiratory service, young adult service, and the specialist nursing home. We also at the RHN currently have 4 music therapists and 1 music therapy assistant, and we also have 2 music therapy students on placement with us. And we cover all of the services, and the music therapy department is completely fundraised for by the hospital. So our first presentation today is from me. I'm Alice Hardy. I'm one of the music therapists here. And my case study is called Where Am I? A case study using musical mnemonic training to support orientation for a patient with Huntington's disease. So Huntington's disease is a progressive neurological condition. It's caused by a faulty gene in our DNA, and the genetic instruction, which is the genetic instructions that tell our cells what to do. So when this gene malfunctions, it affects the brain and the spinal cord and the nervous system, and it can lead to a wide range of symptoms. And there's currently no cure, but treatments and strategies can help manage symptoms and improve quality of life. The 3 main areas that are affected are thinking, movement, and behaviour. And this can include issues like memory loss, involuntary movements, and personality changes. The condition is inherited, so if one parent has the faulty gene, there's a 50% chance that this will be passed on. So neurologic music therapy is an evidence-based approach that uses music to support brain function and rehabilitation. It's grounded in neuroscience, and it focuses on how music can engage and stimulate non-musical brain processes like movement, speech, and cognition. And there's about over 20 sort of clinical interventions that are involved in the NMT. So one of them is musical mnemonic training. So that's one of the cognitive interventions, and it uses melody, rhythm, and structured musical cues to support learning and memory. So it leverages the brain's natural ability to encode and recall information through music. And it's really effective for tasks that involve sequential memory. And it often uses sung or chanted phrases paired with rhythmic repetition. And it's particularly helpful for people with neurological conditions that affect short-term memory. So the therapeutic mechanisms that kind of underline this technique is that it targets the memory system, including prefrontal lobes, the hippocampus, limbic system, and the cerebellum. And research has shown that music enhances the functioning of brain areas used for learning. So the Peterson and Tout study measured brain waves with EEG and found that music enhanced networks for verbal learning in the frontal lobes. And melody provides cues to help recall words of a song. Melody and rhythm was found to be superior to spoken presentations in helping the recall of ideas. And also studies show that singing helps people with memory problems enhance memory for names and for people. So the case study I'm going to talk to you about today is about a 67-year-old gentleman with a history of Huntington's disease and anxiety. He was previously living at home with his wife until his behaviour became unmanageable, and he presented with global choreic movement. He did have motion in all 4 of his limbs. He demonstrated impulsivity, especially when attempting to stand up on his own. He showed quite severe and global cognitive deficits, such as reduced attention, impaired memory, and reduced idea generation. And this caused a cognitive communication impairment as well. He was really frequently disoriented to time and place, and he would repeatedly request to go to hospital and to state, "I don't know where I am, I feel like I'm in a bubble." And these episodes would quite frequently escalate into distressed behavior, where he would attempt to lie down on the floor and he'd become verbally and physically aggressive towards the staff. So referral for music therapy was made by the multidisciplinary team. And this was for joint sessions with physiotherapy to work on his balance and coordination. But it was also for individual music therapy sessions to focus on his orientation and his emotional expression. And he also frequently attended the weekly music therapy group that was held on the ward. So this is the song that I wrote for him for our sessions. And it targets episodic memory. So that's your memory for specific events and experiences, which helps you to remember when something happened, when, where you are. And also for semantic memory, which is memory for facts and general knowledge, which can support orientation by helping to know the name of the city you're in, the day of the week, things like that. So the brain system and the function that is targeted with this is looking at memory consolidation and recall system, which involves bilateral temporal lobes, limbic system, and the cerebellum. So I'm going to play you the song quickly. I am in hospital in Putney, London. Right now, this is where I need to stay. I have nurses and therapists and doctors who help me, trying to remember every day. You can tell I had a bit of fun in post-production with that one. So we would sing this song at the beginning and the end of each of our sessions. And in between, we would sing other songs, kind of focusing on his mood, engagement, and communication. And then after the song, I might ask him some follow-up questions like, you know, do you know where you are? What city are we in? Just to kind of check his learning and his understanding of the song. And after a while, the patient did begin to independently remember the lyrics during the session. And I actually could sometimes hear him singing it in the corridor outside of sessions as well. So the outcome of that was that he began to independently recall song lyrics outside of the session. And the instances of the patient sort of bringing himself out of his wheelchair and onto the floor gradually declined until they stopped completely. And his behaviours that challenged became a lot more manageable overall, and the patient was able to be discharged to a nursing facility near his home with some guidelines for his behaviour management. So overall, it was a really great outcome for this patient that we had. I've popped some references there. We'll be sending out the PowerPoint, I think, afterwards, but there's some references there for things specifically to do with what I've spoken about. All right, so next up, we've got Ollie.
Hi there, my name is Oliver. I'm a music therapist here at the RHN, and my presentation is titled Supporting Expressive Communication, a Therapeutic Songwriting Intervention with a Patient Receiving Care on the Ventilation Service. So a bit of context about my work at the RHN. Music therapy has recently secured 1 day of designated funding for provision on the ventilator service. The service consists of 2 separate wards that cares for approximately 30 patients. And due to demand, patients are primarily seen within the context of a weekly music therapy group, which alternates between the 2 wards. And interventions are primarily aimed at supporting quality of life goals in the domains of communication, emotional expression, and social interaction. And I also see a small number of patients on an individual basis subject to availability and clinical need. So a brief overview of the patient that this case study is going to focus on. Mr. G, which is obviously an alias, is a young man in his early 30s. He was admitted to the RHN in June 2024 after suffering a basilar artery stroke, and currently requires 24-hour ventilation and support with most aspects of his care. The stroke was related to a history of blood clotting conditions, and he's able to communicate using gesture, typing on his tablet, and writing using his right hand, but he's non-verbal as he's receiving invasive ventilation. He requires prompting and encouragement to write accurately, and prior to therapy was presenting with a lack of motivation towards communicating and engagement with therapy in general. So Mr. G was referred to music therapy due to having a perceived low mood state, as well as reduced engagement with therapy, and his overall communication skills and willingness to communicate, particularly around matters relating to his emotional well-being, and also his functional upper limb skills relating to his handwriting. And there was a general perception amongst the MDT that Mr. G was not communicating about his mood and feelings. He was declining to participate in therapy, and he wasn't engaging with psychological interventions either. So the aims of therapy that were established were to encourage and provide opportunities for communication around topics relating to feelings and emotions, to promote engagement and motivation towards participating in therapy, and to support his functional motor skills, specifically his upper limb skills and his handwriting as a means of him communicating. So the intervention itself lasted 12 sessions, and it was to support Mr. G to participate in a structured therapeutic songwriting program with the aim of providing opportunities for communication, emotion expression, and supporting his adjustment to injury. The rationale for choosing this intervention is that therapeutic songwriting can be helpful for patients who are perhaps unready to communicate about feelings around a loss or an injury directly. And studies have shown evidence for improved satisfaction with life, expressive communication, and emotional regulation. And I've got a little definition of therapeutic songwriting down there, which is taken from Baker and Tamplin's book. So the first phase of the intervention, which lasted from sessions 1 to 3, involved building a therapeutic relationship. This involved listening to music together and establishing the patient's music preferences, which turned out to be 90s hip hop and R&B. We identified a song archetype, which represented the kind of song that Mr. G might be motivated to make. This song was Dear Mama by Tupac, which is like a mid-tempo hip hop track, which contains both rapping and sung vocal refrains. We also spent some time discussing the patient's pre-admission history, his family, his values, his interests, and we discussed what kind of topics Mr. G might like to base his song on. The second phase of the intervention involved creating a backing track together for the song. This ran between sessions 4 to 6. This was done using GarageBand for iPad and involved supporting Mr. G to select all of the instrumental components of the track, from a breakbeat to a bass line, keyboard, string, and piano parts. We were referring to the song archetype we'd identified throughout the process. And GarageBand for iPad is ideal for this kind of intervention, really. Obviously, hip-hop music typically uses lots of loops and samples, and there's a loops composition function built into GarageBand. There are also lots of adapted instruments which are ideal for disability access, which allow patients to make composition choices via touchscreen. The third phase of the intervention involved lyric generation, and this happened between sessions 7 and 10. During this stage, I referred quite closely to Baker and Tamplin's therapeutic songwriting protocol, which is they identify a 3-phase process of lyric generation, which involves reflecting on past conceptions of self, values, and interests, present conceptions of self, values, aims, and interests, and future conceptions of self, values, aims, and interests. And the aim of this is to bring about a more integrated sense of self following an injury or a loss. We then went into a phase of sort of lyrical consolidation. We had themes for these past, present, and future notions of self and values, and we utilized an application called Rhymer's Block quite a lot in this process, which was helpful for generating rhymes, which are obviously central to a lot of hip hop and rap music. The patient was supported to provide all of the lyrical ideas via writing, which was working on his upper limb goal, and his writing gradually became more consistent and legible. We used the backing track throughout the process, which was helpful for inspiration and also as a rhythmical reference for developing the rhythms of lyrical phrases. And yeah, here I've noted some of the themes that were identified by the patient as important to him in the prior phase. We've got a transcript here of the lyrics that Mr. G generated, which you're very free to have a look at afterwards. And we made a few other sort of important composition decisions in this phase of therapy. We settled on the title So Lonely, which was chosen by the patient. Again, we referred quite closely to this song archetype that was identified at the start of the therapy process. We use this more as a reference point and for creative inspiration rather than as like a song parody technique, because I felt that the patient's cognitive ability was sufficiently good that we could create an original song. We also decided that, well, Mr. G decided that he wanted to begin his lyrical narrative from his present feelings and circumstances and then moving towards reflecting back on important memories and events prior to injury. And he wanted to dedicate the song to his family and provide them with a recording. So the final phase of the intervention involved recording and producing the track itself, which was done in the last 2 sessions. The decision was made for Mr. G's nephew, who fortunately for the intervention is a young musical artist and rapper, to perform the rapping and vocals on the song. So a recording session was arranged at the hospital, which was attended by Mr. G's nephew, family, for the vocals to be recorded. Mr. G was also supported by staff to attend the session and was able to make creative suggestions during the process. And then I mixed the track afterwards. So we've got a little excerpt of the finished recording here, if we're doing okay for time, which I think we are. Hopefully you can hear this, which Mr. G gave us permission to hear today, very generously.
This goes out to Janine, Lakeisha, Ishmael, Nathaniel, Mom, Dad, and Michael. So lonely. By myself in a lonely place, trying to keep up these times of strength and grace. Alone by myself with some time and space. You know it's hard to try and keep a smile on my face. Thinking about food and beer too much. A snack and a drink would be a touch. Watching over people eating on the TV. All this watching's got me feeling really hungry. So lonely. Yeah, my mind. 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 Thinking about the days back in Abbott's Park, riding bikes, playing football, having some laughs with Ishmael, Nathaniel, my hometown boys. Now we're onto family, less time for the boys. Wondering how the time seems to go so soon. Now we only go back once in a blue moon. From late into the darkness as a business analyst. You and Nathaniel in recruitment businesses. So lonely. Yeah, my mind. 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 So lonely. Yeah, my mind.
Okay, we'll stop it there for time, if we can. So yeah, that's the finished song, and a bit about the outcomes of therapy just to finish. Mr. G was able to successfully compose and record an original song, communicating and expressing thoughts and feelings around his injury experience. He was also able to share the song with his family, as well as involve them in the creative process, which was really lovely. He demonstrated improvements in his participation and engagement in therapy and is now a regular attendee of the ward music therapy group and is showing signs of engaging more in other therapies. He showed improvements in his communication skills and willingness to communicate throughout the process using his writing ability, and a willingness to communicate about his feelings and emotions with other members of the MDT, which was important because the process was able to give the other staff in the therapy team a bit of an insight into where he was at, what some of his goals were, and how he was feeling. And he's scheduled to attend a ventilation day event later in the week, where he's also going to share his song and his story, and he obviously gave permission to share the song today. So yeah, and I've got a few references there that informed the work. Thanks a lot. And I'm going to hand over to Amanda.
Hi everyone. So I'm going to take my glasses off because it looks like they're a bit dark. Hope I can still read the notes. So my name's Amanda, and I also work at the RHN, specifically on the brain injury service unit, where we focus on rehabilitation of patients with complex brain injuries. And I'm going to be talking about the use of music therapy to enhance motor learning in the rehabilitation of a young man who had suffered a significant traumatic brain injury from a big fall. The lyrics that are presented on this page are actually of the preferred song that we ended up using frequently in the music therapy sessions, whether we were working on voice, rhythm, and then ultimately his physical movement. And the reason why I included them is because not only is it his preferred song, but it was also very poignant. The lyrics were very poignant given his circumstances. And then one of the challenges that we face when we have a brain injury is the cognitive load that puts on, and by actually losing ourselves in the music, we can actually reduce the cognition efforts that are required to engage with walking, thereby making it slightly more fluid. So movement is humongously important to all of us. You know, it's our heart, it's our body, it's our breathing, it's our moving, it's a necessary part of life, you know, whether we're seeking food, shelter, running away from people, or just demonstrating independence and a freedom. But it's also a really important part of self-expression. So to be able to communicate what we are feeling is very embodied in how we present ourselves physically. Finally, it's also social communication, the amount of times that we mirror people, the way in which we bond with people through aligning our movements with others. So if you think when you're walking down the street with a friend, you invariably fall into a natural rhythm of walking with them. And all these things really contribute to the importance of movement and why it is such a key element in rehabilitation of brain injury. So the impact of traumatic brain injury, significant number of people have mobility impairments after brain injury. Again, here it's a very sort of complex unit that we're working on. So whilst the statistics says 30% of patients have mobility impairments after TBI, our percentage of people with mobility impairments is closer to 90 to 100%, definitely on the ward I'm on. So the challenge with that is it's really, you know, the less stable you are in your movement, in your walking, the more likely you are to fall. You know, it's challenges with assistance from getting from bed into a chair, and all these things, increased level of care, lack of independence. And so one of the studies that I had read about was talking that, you know, even if we sort of, you know, the ultimate goal is for somebody to walk, the actual improvement of going from a standing frame to a steady transfer is, you know, even if it's an incremental benefit, it's hugely important to the psychological well-being of the individual. So any form of movement towards a more independent state of being is just fundamentally important to what we want. So the other challenge is, again, it's not just physical impairment, it's a cognitive impairment because of the planning that we need to go through in order to do the execution of the movement. There are multiple areas of the brain that are involved, but primarily we're looking at the motor cortex and then the other areas for planning and coordination and making everything work holistically so we can respond and react and initiate movements within the environment. The main impairments that we come across: ataxia, so this is the actual movement coordination; apraxia, where it's the planning and execution; and then there are other issues like sensory and proprioceptive impairments, where you are struggling with where you are in time and space and how to move in coordination with those other things. Again, it's not just physical, it's going to be a cognitive challenge. So in the early 70s, there was a lot of work that was done on rhythmic synchrony, primarily with Parkinson's patients. And this is thinking back to when we were talking about if you're walking with your friend, you may walk in time with somebody. So this external auditory stimulation that we sort of lash onto is something that we can start to entrain motor responses to. The brain is listening to the gap rather than the beat, cueing a motor response to initiate the action of the stride of the walk. So this is why we're looking for external stimuli to engage that initiation of movement. That's great if you can hear the beat and you can decode the beat, but there is a temporal processing and beat deafness issue. So if you're working with somebody and they actually cannot lock into a beat or hear a beat or respond to a beat covertly, then it is going to be quite difficult to use the rhythmic auditory stimulation, which is what you're wanting to drive the movement. So moving into the case study, looking at how we could work with this young man who had significant brain injury. Sorry, that slide seems like it's missing some of the information about him. Where is that? So he was 28 years old. As I said, he'd had a significant fall, and it was very diffuse spread, widespread damage. So initially we had to just work on voice and communication, emotional well-being. And then as he was actually making such significant progress, goals started changing more into that functional physical movement that he was starting to be able to move from from the bed to the chair with less help. And then we wanted to try and get him to be able to stand from the chair independently. Oh, there are my other bits. Don't know why that went that way. Sorry. Anyway, we had 40 sessions. And as I said, the goals were adjusted to focus on this increasing independence. And the last 8 sessions, or the last 10 to 12 sessions, we had 8 joint sessions with the physio. This was specifically to work on his functional rehabilitation of moving, of standing, of sit to stand, and then walking. So with the physio, we looked at his walking before and after the music therapy sessions. And so I'm just going to move quickly into the pre-video and talk over it. So this is him walking. You can see there's a slight sort of unequal gait. He's spending a lot longer on the strong leg. The step stride is quite small. And then when he goes to open the door, he has to stop and think about what he's doing before initiating the door and then starting up on the walking again. So going into the session, I'm not going to play all the videos. I'm sorry. I think it's more interesting to see the before and after to see if you can see any changes. But we started off using the actual recorded song. The challenge with using the recorded song is we can't actually shift the tempo to go with his natural cadence. So we moved to the guitar and using the guitar. So there was still that external cue that we were giving him, but it meant that when he lost the metronomic beat, we were still able to provide that external stimuli, because once he lost the metronomic beat, trying to get back onto the beat was very difficult for him. We did step weight bearing exercises, so just moving from foot to foot. Then we did stepping out, and then we did stepping forward. And we increased the complexity of the things that he was having to do as well. So increasing the cognitive load to see if he could still maintain his walking. So this is him after, and you can see the step is more equal. The stride is greater, and he's going to be coming up to the elevator any second now, and you will see quite a smooth, continuous turn rather than a stop. There he goes. He's just gone around the corner. So rather than a stop, reorienting and then continuing, it was all one continuous smooth movement. So his mobility progressed, supervision went down from 2 people to 1 person, then walking independently without aids. There was a reduced risk of falls. He certainly felt an increased sense of independence, functional ability. He's been successfully discharged home. And with all that sort of reduced care burden, there's been reduced cost of care. He is still continuing therapy in the community, and he's hoping to go back to work. So I think that the music and the song, as well as the joint sessions with the physio, really aided in his progress. So thank you. And now I'm going to hand over to Michael.
Thank you, Amanda. I'm just going to try to increase the screen brightness a little bit for me. Okay, great. So hello, everybody. My name is Michael, and I'm one of the music therapists here, and I think I'm your last presenter today. So I'm going to be talking to you about a case in which I helped a patient improve her mood with therapeutic songwriting. So I'm going to go through some different things about her case. I'm going to talk about the diagnosis and the background, why she was referred to music therapy. I'll talk about the intervention that we used and our process, and I'll show you what we created. And I will talk about the impact evaluation as well. So I can report some outcomes for you. And I will wrap it up with some considerations for you if you'd like to use any of these interventions in your own work. So some disclosures: this patient provided consent for her song material to be shared in this presentation, and a pseudonym is used in the presentation, and some identifying information has been changed or removed. So a background for her: her name is Mandy. She was a 50-year-old female, and she had a large stroke affecting the right side of her brain. So her presentation from a physical point of view: she had weakness on the left side of her body. She was a wheelchair user, and she was fully dependent on a hoist for all transfers. From a communication point of view, she had muscle tension dysphonia and no functional speech. She was not able to speak at all. She had a tracheostomy, but was recently removed prior to her work with me. She used AAC, so this is alternative and augmentative communication. For her, she used a high-tech AAC, text-to-speech, in which she texted phrases and then the device would speak out her responses, and she was very proficient and fast at using this. No language impairments. Cognitively, she had difficulties with sustained and alternating attention and executive function and inhibition, and she didn't have much insight into her cognitive difficulties. From a mood point of view, she did experience anxiety and low mood, and she reported that she was experiencing Cotard's syndrome, which is a rare neurological condition where a patient feels dead and does not recognize themselves in the reflection. So before her stroke, she did have a history of mood difficulties and a previous diagnosis of bipolar. Some social history for her: she had recently moved to the UK from Australia to help her daughter get settled into university. And she was previously fit and active and was previously working full-time as a data analyst. So quite high functioning before. So for music therapy, she was referred by the multidisciplinary team to work on her vocal function, her upper limb skills, mood support, cognitive skills, thinking skills. So she was referred for quite a lot of things. In my first session with Mandy, I asked her to prioritize what she would want to work on. And I have listed the priority of what she said here. So for those who are not able to see it, first priority for her was her mood. Second was vocal function. Third was her upper limb skills, and fourth was her cognitive skills and thinking skills. And if you remember before, she didn't have much insight into her cognitive difficulties, and she denied needing support with that. So as per her wishes, we prioritized mood, and the interventions that I offered her for this were song lyric analysis, therapeutic songwriting, or expressive improvisation. And the intervention that she chose to do is therapeutic songwriting, which Ollie has helpfully introduced already today, so you have a bit of a background on what that is. And the second priority goal for music therapy was vocal function. And for this, we decided to do some NMT exercises like vocal intonation therapy and therapeutic singing. And I do have some references at the end of this presentation, so you can do some more reading on those if you wish. She did have some more interventions for her mood, which is important to note. She had weekly sessions with psychology and referral to neuropsych, and she was on 2 antidepressants. She also had additional interventions for her voice, which included weekly sessions with speech therapy and a self-directed voice program, which she did in her own time. So the focus of our work together was really the mood support and the therapeutic songwriting. So I'm going to talk about that mostly in the presentation today. So this was our process for therapeutic songwriting. Because she did have some cognitive issues, she required quite a structured and supportive approach, and these are the supports that we used. So to generate some context and inspiration for her song, we created a playlist together and decided to choose one of the songs to parody. And to create further themes and context for her song, we used visual creative prompts. And for the lyric generation, we used the support of AI, ChatGPT, to help initiate some ideas for lyrics. And to generate the melodic ideas for her song, we used a graphic notation approach. And I will briefly go through all of these with you. There was actually a kind of fourth phase, which unfortunately happened after her discharge from the service. So I did that. So that was instrumentation, recording, and editing the song together. And I was able to send this to her after her discharge. So she does have the song now. So the first step of the process with her was creating a playlist of inspiring songs that kind of reflect her rehabilitation journey. And these are the songs that she chose to add to her playlist. And if you aren't able to see this, it's Ironic by Alanis Morissette, Purple Rain by Prince, and I Want to Break Free by Queen. These are songs that she chose. They were important to her and reflected her rehabilitation journey. And she wanted to write a song that evoked similar themes and feelings to these songs. So the task was to choose one. So she chose I Want to Break Free by Queen. And this is the song that we based her song off of, rhythmically and harmonically. So the second stage of our process was visual creative prompts. So we used these creative prompt pictures, and we looked at each one and decided how they resonated with her. And I asked her to choose one picture that resonates the most with her and kind of reflects her feelings of her journey of rehabilitation. And the picture she chose was the middle picture. If you aren't able to see this, it is a picture of a girl holding a bunch of red balloons, and she's floating up into the sky and floating over a beach, and there's a sunset, and it's quite peaceful. So this was her favorite picture of the options that she had. And the task was to build a story for this picture. So who is the little girl? What's happening in the picture? And what journey has she been on? And from that, we identified some emerging themes. So the next step of the process was to generate some lyrics. And for this, we used the support of ChatGPT. So with my support, she created a prompt for ChatGPT to generate song lyrics to illustrate her story that she came up with for the picture and to include the themes of the story. And the prompt to ChatGPT included an instruction to leave blank lines and spaces for her to fill in her own personal details to make the song more personal. So this is the prompt that we generated together for ChatGPT. So it is, write a song in the style of Queen, I Want to Break Free. This song is about a young girl holding red balloons floating across a beach in Australia. The song themes are resilience in the face of difficulty and a mother's strong relationship with her daughter. Please leave blank spaces to fill in to make the song more personal. So moving on to the next phase, which is graphic notation for melodic ideas, we used a graphic notation approach, which I have displayed here. And for this approach, I made her worksheets with the song lyrics, and above each phrase of lyrics was a space for her to draw in her melody. So literally draw the shape of the melody. And by that, I mean drawing a line up for the melody line to go up and drawing a line down for the melody line to go down over the corresponding words. So she's literally drawing out the melodic shapes to generate the melodic ideas for the song. And this is what we created together. I will, so I have the lyrics here on the left-hand side and the graphic notation on the right-hand side of your screen, and you can kind of compare those if you can see it. And I will just play the song first verse and the pre-chorus for you. Suspended in an orange breeze, over golden sands and into seas. Just a whisper of air, she flies up with a flash, looking down at the waves that crash. With a smile like sunlight that brightens the sky, she hollers out, I'm dead but alive. So for the purpose of timing, I'm not going to play the rest of the song, but you can see how the melodic lines kind of match with her melodic shapes that she drew in the graphic notation activity. And I think I'm going to have to wrap it up pretty quickly, but I do have some outcomes I want to share with you. So in music therapy, it's always important to measure the impact that our work has on our patients. And for this, I used the Music Therapy Impact Areas Questionnaire. And we administered part A of this questionnaire. So the Music Therapy Impact Areas Questionnaire is a music therapy evaluation tool designed to assess the impact of music therapy on a variety of people and groups. And part A is the part that service users, so the people receiving music therapy, fill out. So that's why we did that. I thought this was a really good tool to use for her and for this case. And if you'd like to use it yourself, I've linked a QR code at the end of this presentation for you to access this tool. And there's a standard version and an easy read version as well with pictures if your patient requires some picture support. So in terms of the impacts that she reported that the intervention had a very positive impact on the following things. I'm not going to read each one out for you, but for example, it's things like supporting her relaxation, enhancing her quality of life, and increasing her confidence, and reducing her negative symptoms. And she reported that the intervention had a positive impact on enabling her social skills and interaction and providing emotional support. She reported that the intervention wasn't very applicable to her communication skills or her physical skills. And there is like a qualitative comment box as well. And she commented this comment. So she said, I'm very grateful to you for engaging me in this exercise. It has improved my mood and reminded me that I can write and that I am eloquent. And I'm just going to briefly go over some considerations if you'd like to use AI in creative therapies. There are some benefits like idea generation, particularly for patients with cognitive or language issues. There are obviously some ethical considerations, however, it's important to to avoid over reliance on the use of AI, and it should only be used as much as it's needed. It should be balanced with personal human interactions, which is obviously like the cornerstone of music therapy, which is based on relationship between therapist and client. There are some risks to be aware of as well, which are important to just go over. The information that you input into ChatGPT is permanently stored. ChatGPT does not meet the requirements for GDPR. And it's important to not input any personally identifiable information like name, birthdays, addresses, etc. If a patient does want personal information in their song, put this in after you use ChatGPT. So these are my references that have informed my presentation today. And as I said, if you want to read more about the Music Therapy Impact Areas questionnaire, you can scan the QR code now, and that will link to the article and some appendixes, one of which is the questionnaire itself. So that's the end of my presentation, and I think we're going to have questions for everyone now. So how do we want to do that? Do you want to come over, Anna? Cool. You want to get them in?
Thank you. So if you've got any questions, do pop them in the Q&A tab at the bottom. And also just want to say thank you so much to the whole team for all your presentations and your case studies. And this talk will be recorded. So if any of your colleagues have missed it today, it'll be on our website and on YouTube later next week, and we can email it out to you. So you've got a copy of a link that you can forward on to anyone else you'd like to hear this talk. Yeah. So any questions, do pop them in the tab now. We'll hold on for a few more minutes. Okay, we've got a question just come through. Do service users need to be musical or have a musical background? And how do you assess who's a suitable candidate for music therapy?
So the answer is no. Patients don't have to have music skills or musical background. Music therapy works on non-musical goals, so functional goals like communication, thinking skills, physical skills, and it's based on the music's response on the body, kind of like the biological effects of music on the body. So the effects of music therapy kind of work for everyone. I don't know if anyone else has anything to add to that. I'm just going to hand you over.
In my personal experience, sometimes when you work with a service user was very musical before, had high musical skills before, it can actually be quite difficult for them to engage in music therapy. It's quite a stark reminder maybe of some skills that they had and they've lost. So that can add an extra layer of a challenge to it. Whereas often if you work with people that didn't really have any musical experience before, there's not that level of expectation that they have on themselves. So they can often be a bit more open to it, and it can be really successful. So musical skills shouldn't be a barrier to accessing music therapy.
Was there a second part of that question?
Yeah, how do you assess who's a suitable candidate?
We would do an assessment session with them to look at why they'd been referred and to kind of explore different areas that music therapy could have an impact on them. Yeah.
Thank you. So the next question we've got is, can music therapy be used alongside other therapies? And if yes, can you give some examples?
Yes, it can. So we try to be as collaborative as possible. So for example, with my case, because the primary aim we were working on is mood, I worked very closely with the psychologist that was seeing my patient to understand what supports they were doing in their sessions, what techniques they were doing in their sessions. So for example, my patient was doing like some self-soothing strategies that she was learning in her psych sessions, like mindfulness, breathing, relaxation, and we would try to incorporate that into our sessions when appropriate. I'm sure my other team members have other things to say.
Yeah, similarly to Michael with my intervention, I work very closely with the psychology team as I mentioned in the presentation, there was a feeling that my patient wasn't willing or ready to engage with psychological services. So the outcome of the intervention sort of informed how the psychology team then approached working with him afterwards.
Hi, yeah, so I was just going to say that also the presentation that I did, I had 8 joint sessions with the physio, and the physio and I collaborated outside of those sessions as well to ensure that anything that I was doing was safe. The physio is the physical specialist and I am the stimuli specialist, the musical rhythmic specialist. So also with speech and language, we work very closely with speech and language, especially when we're doing any kind of voice work. Again, sort of recognizing the specialty of the other professions, and the specialty that we bring is the sort of combination which makes it really powerful.
And I think it's important to mention that certainly at the RHN, the way the music therapists work is very much in support of the multidisciplinary team. So when we're setting goals and objectives for our patients, we're really taking into consideration what are their overarching goals. It's not just I'm the music therapist working on a music therapy goal. It's we're looking at those broader goals that are relevant for that patient and how can music therapy support that. So it could be that we're working on a goal that's actually an occupational therapy goal or a speech and language therapy goal, and we're using music to then support that non-musical functional outcome for that person.
Thank you. Taylor's got a question. At what level would you suggest is the minimum for a patient's cognitive or communication abilities to be able to engage in music therapy? They say we currently don't have access to music therapy and have a lot of patients post-stroke with both severe cognitive and communication difficulties.
So we work with patients with severe and profound cognitive difficulties. Cognition isn't really a barrier to benefiting from music therapy. So for example, we work with patients in prolonged disorders of consciousness, and we're part of the assessments that they receive. In terms of actively engaging in music therapy at a higher level to do things such as exercises to help with speech and exercises to help with physical functioning, some cognition is required. So it is important for the patient to be able to understand instructions and that sort of thing. So it kind of depends on what the music therapy is focusing on. But music therapy has something valuable to offer everyone, regardless of what cognitive level they're at.
Yeah, and speaking from the perspective of working on the long-term care service, where we have a lot of patients who have higher levels of impairment, often music is something that they can still access when they're unable to potentially access other areas. So for example, if we're looking at like communication impairments or quality of life goals, music might be an area where expression can be facilitated where it may not be possible via speech, for example. So sometimes that can be helpful.
Yeah, I think the sessions, you can sort of think of them on a spectrum of maybe when you've got higher cognitive impairment, it might look a bit more like a passive music therapy session or more receptive methods, which are useful. And then you can go along that spectrum into more engagement and more active music therapy. So it can look different, but there's lots of different benefits kind of wherever you are on that spectrum.
Final addition. Yes, again, it's a non-verbal therapy primarily, and we are working on unconscious brain activities a lot of the time. I referenced losing ourselves because the cognition that we put on top of things can quite often get in the way of what we're actually doing physically, and you can still learn through motor repetition a lot of the necessary movements and engagements with life and the environment without necessarily knowing what it is that you're doing. And then for the speech and language challenges, 7% of our communication is language based, the rest is prosody and behavioral movement expression. So really thinking, how can somebody else express themselves if they have expressive aphasia or other verbal language disorders is a huge window for them. And a lot of patients you may have seen with dementia or expressive aphasia where they can actually sing a song from beginning to end, even if they can't put a sentence together and initiate a sentence. But the actual reward that those people, the emotional reward that people feel having been able to sing from beginning to end is valuable in and of itself.
Thank you. Okay, we've maybe got time for a couple more questions.
Yeah.
Okay, so we've got a few more coming in. How often do you see patients? Does it depend on the intervention and client?
Definitely it does. I mean, usually I would try and see someone at least once a week, but there are some interventions, especially when you're looking at neurologic music therapy techniques such as melodic intonation therapy, where the recommendation is shorter but more frequent. So sort of maybe only 15 minutes, but 3 times a week. But as a rule of thumb, I tend to see people once a week.
Yeah, I think again, it really depends on what the goal is that you're working on. Any kind of motor learning requires repetition. So if you can give different repetitive exercises to people and they can do them independently, or if other people on the team can support that repetition, that sort of everyday touching, family members are always really eager to also support their loved ones. So engaging people in sort of exercise programs is really good.
Thank you. And perhaps one more from Yim Ching, who says, would the work be different for non-English speaking participants, or were they included in your studies?
That's an interesting question. I think, so for people who don't speak English, it can obviously be difficult for us to engage them if we don't speak their language, but we try to meet their cultural needs as much as we can kind of in the assessment phase. And if they don't speak English, that's something that will certainly be like flagged to us in the kind of referral stage of music therapy. And we will try to engage with interpreters because we do have access to work with interpreters here. If language is an essential component of the intervention, so if it's like a songwriting, for example, or an assessment that requires the patient to understand instructions, then we could engage with interpreters. But in terms of meeting their cultural needs, we certainly try to, as much as possible, use music that's relevant to the patient's culture. Does anyone else have anything they'd like to add to that?
I was just going to say,
it's a good question.
Yeah, obviously we've covered quite a few different areas, so it depends on kind of which area you're talking about. Obviously, the studies that I mentioned were not done by us at the RHN, so I can't speak to as if they were done with English-speaking participants or not. But yeah, I think that we just have to do what we can to support that person to engage, whether it's using interpreters or sort of using other methods of communication that can potentially get around that barrier, and always kind of trying to offer that person-centered care using music that's relevant to them, finding out about their sort of cultural history and their preferences from family and friends and things like that.
Thank you. I think we're out of time, but just a big thank you to all of you. And like I said, it's been recorded, so if anyone missed it, do watch it on our website, on YouTube next week onwards. If you've got any questions, we didn't come to your questions, please get in touch. You can email us at institute@rhn.org.uk and we'll happily come back to you. But thank you for joining us today.
Okay, thanks everyone.
Thank you. Goodbye.